Hello, good morning. I'm Shamik Bafna. I'm a cataract and refractive surgeon over at the Cleveland Eye Clinic, and today we're going to be talking about extending the view of EDOF technology. These are my financial disclosures. So basically, when we want to talk about presbyopia correction, it's a balancing act between three interrelated concepts. Basically, increasing the overall depth of field can potentially reduce your overall visual quality and increase different dysphotopsias. When we talk about dysphotopsia, it's very familiar to all of us. We're talking about glare, halos, starburst, flare, things of that nature. Now, if we lean towards EDOF technology, extended depth of field lenses, they basically have been designed to bridge the gap between monofocal lenses and multifocal lenses. They're designed to increase the depth of focus, but at the same time minimizing overall side effects. If I look at EDOF technologies in general, there's broken down into four different categories. There is spherical aberration, number one. Number two would be diffractive optics. Number three, zonal optics. And number four, aperture optics. So we're first going to go ahead and talk about spherical aberration and how that's being employed. So if I look at the entire eye, spherical aberration is broken down into two surfaces dealing with both the cornea and the lens. And we have to look at the overall spherical aberration of each of those entities to look at the overall eye level of spherical aberration. Basically, as we reduce the amount of spherical aberration, we increase the quality of vision. Thereby, in the opposite way, when we go ahead and increase spherical aberration, we potentially can decrease the amount of quality of vision. At the same time, inducing spherical aberration increases the quantity of vision or depth of focus. So like I said before, sort of a balancing act here. The monofocal plus category was first marketed by Johnson & Johnson. And the lenses, basically this category meant that there would be lenses with the side effect profile of a monofocal lens, but with increased range of vision. These lenses, however, did not meet the EDOF criteria that was established by the FDA. So the first lens marketed within this category was the Tecnis Eyehance. And if you look at the lens, there was a power change that continuously increased from the periphery to the center of lens. It thereby, by creating this unique anterior surface, we would go ahead and provide improved intermediate vision compared to an aspheric monofocal IOL. It provides for distance vision comparable to an aspheric monofocal lens, and at the same time deliver a dysphotopsia profile similar to a spherical monofocal IOL. Now, there are many lenses Clarion wanted to look at to see, was there much of a difference between their lens versus an Eyehance? So there was a study done by Morgan Micheletti looking at a comparison between Clarion lenses by Alcon and the Eyehance lens. And basically what they found when they compared this lens was there was no significant difference in the defocus curve between these lenses. The reality is that most of the newer generation monofocal lenses probably can fall within this monofocal plus category. Light adjustable lens is another unique lens that goes ahead and optimizes visual quality after cataract surgery. The thing that's unique about this particular lens is its adjustability. We can go ahead and using light, we can affect the different macromers on the lens that will change the morphology or shape of the lens, thereby impacting the overall spherical power. Now, when we go ahead and apply the light on the light adjustable lens, it can actually create EDOF by changing the overall amount of spherical aberration. Most recently, we've now gotten the introduction of the LAL Plus lens. And when you look at the defocus curve between the LAL Plus and the LAL lens, you can see that the LAL Plus is flatter, thereby increasing the overall defocus of that lens. So this lens can potentially go ahead and increase the amount of range of vision. Rayner EMV is another lens that many of us may not have heard of, but what's unique about this lens, it actually creates positive asphericity. If you go from the periphery of the lens toward the center of the lens, whereas most lenses tend to induce more negative asphericity, this particular lens creates positive asphericity. Now, if I look at a cornea in general, in the center of this illustration, it represents a normal cornea, virgin cornea, that typically has a slightly positive amount of spherical aberration. If a patient undergoes myopic LASIK, which is on your left-hand side, you can see that it flattens the cornea, thereby inducing positive asphericity. But on the opposite side, if someone undergoes hyperopic LASIK, it creates steepening of the cornea and creates more of a negative asphericity. Same way, when you look at these various IOLs, starting from the left-hand side, the Rayner EMV has positive asphericity. We move centrally, the Bausch & Lomb Invista lens has zero asphericity, and we go all the way towards the Tecnis Eyehance or the Clarion, and those tend to have negative asphericity. So if you want to pair different corneas with different lenses, if someone has had myopic LASIK where you've got positive asphericity, you want to go and place a lens in that has negative asphericity to try to basically balance the things out. Similarly, if someone has had hyperopic LASIK where they tend to have negative asphericity within their cornea, it would be beneficial to pair it with the Rayner EMV lens that has positive asphericity. So we've talked a lot about spherical aberration as far as creating EDOF. I'm going to now talk about diffractive optics as another approach. The lens that probably is most well known of in this category is the Tecnis Symphony lens. It has diffractive rings that go ahead and create extended depth of focus vision. Most recently, the Tecnis Symphony OptiBlue was introduced because it improves the amount of dysphotopsia profile by creating filtering high energy violet light that reduces scatter. And that basically helps in this category overall. Let's now talk about zonal optics. If we look at zonal optics, if we go back in time at the crystal lens, which was the first accommodating lens that was introduced into the marketplace, the crystal lens actually introduced something known as the crystal lens HD, all the way on the left-hand side, and it created this zonal optics that created some increased overall zone of vision. More recently, if you look towards the right-hand side, you can see the Vivity lens that has this change on the center, again, utilizing zonal optics. Now with the Vivity lens, it utilizes what's known as non-diffractive X-wave technology. And basically what this technology does is it stretches and shifts the light and it creates a flattening of the defocus curve. And that increases your overall range of vision inside there. Finally, let's talk about aperture optics. So if you look at this lens, this is a cataract surgery that I performed a couple weeks ago. And what lens is this? Well, it's actually a trick question because this actually is a standard monofocal lens. If I look at this patient preoperatively, this is a patient that had a cataract surgery that had a camera inlay placed within their cornea. So if I go back over here, this is the same patient and I put in a monofocal lens. I did not remove the camera, but I put a monofocal lens. The main thing you want to make sure is that you go ahead and target a -1 level of myopia in this situation. But utilizing the same concepts, what happened is we created this new lens called the AcuFocus IC8 lens. It's basically similar to the camera, and what it does is it goes ahead and it creates aperture optics to increase the overall defocus curve. So how does this work? Basically what we're doing is it's designed to filter out the unfocused and aberrated peripheral light rays and allow central light rays to focus onto the retina, thereby increasing the overall depth of field. So basically what all EDOF lenses attempt to do is it's a balancing act between quality versus quantity. We want to go ahead and try to increase the depth of focus, but at the same time maintain the overall quality of vision. So let's go ahead and go over a few cases just to kind of see if we can make this a little bit more clear. So in a normal eye, if you have a cornea that really has not had any type of previous surgery, potentially any of these lenses would do really well. I mean, basically, we don't really have much positive asphericity, so you could choose a negative aspherical lens or a positive aspherical lens or a neutral lens. Let's say someone's had hyperopic LASIK performed in the past. Well, this patient on their cornea, we've established has negative asphericity. So potentially you'd want to choose a lens that either has zero asphericity or the Rayner EMV has positive asphericity. On the alternative side, if someone has had previous myopic LASIK, these patients have a positive amount of asphericity in their cornea. So you would like to choose a lens that has a significant amount of negative asphericity inside them. Post-RK. These patients have more of an aberrated cornea. They have a lot of irregular astigmatism, and it can be challenging. The best lens I find in this situation is potentially to utilize the IC8 Apthera lens because that can go ahead and filter out the peripheral light rays and go ahead and help focus in this clear central light rays. The other lens that I found works very well, because there's a lot of variability from a biometry standpoint, is using the light adjustable lens, because that has a potential that after you've received refractive stability after 1 or 2 months, you can then go ahead and use the light to try to focus things and try to maximize the overall level of vision inside there. Glaucoma. I feel like with glaucoma, it depends upon the level of glaucoma you're dealing with. If someone has mild levels of glaucoma where they don't have any visual field defects, you have the potential of choosing whatever lens you'd like. But in this situation, this patient has moderate to severe glaucoma. The real question is, in this situation, should we really be extending the depth of focus? In my opinion, we should not be. We really should try to consider maximizing the overall quality and contrast of vision. So I would go more with a monofocal lens and potentially just control astigmatism. Some with loose zonules. Well, if you have loose zonules, you may have a situation where you may have some decentration issues with your IOL. Most of these IOLs that have been created for EDOF functionality want to be centered in the center of the cornea. So in this situation, I would choose an IOL that potentially has negative asphericity. Retina pathology. This is a patient that may have some CME or clinically significant macular edema. Again, the real question is, should we be extending the depth of focus? Again, my answer would be no. We want to try to maximize the overall contrast, quality of vision. And so I would choose a monofocal lens, potentially could add in managing astigmatism with a toric lens. So the great situation that it's great to have so many IOL options. It's important to understand what your patient's goals are, and then we can look at those goals and try to determine that we have an opportunity to enhance the overall visual function. We should understand what each technology can and cannot do, and understand what are the advantages and disadvantages of utilizing each of these technologies. Thank you very much, and I want to thank BVI for going ahead and sponsoring this talk. Thank you.